All right, well, why don't we get started? Thank you everyone for joining us for this policy forum. My name is Julie Bershadsky. I am the Director of Community Living and Employment at ICI. I'll give a brief physical description of myself. I am a white middle-aged woman with short hair, wearing a gray sweater with a pretty sterile white wall behind me. Nothing interesting behind me today, unfortunately. Welcome to the Policy Forum. We try to hold these monthly to discuss the most recent issues of our research policy briefs. The policy brief's intent is to provide very focused, simple language, description of an issue, and summarize some research, provide recommendations. The policy forum's intent is then to talk about that issue, brainstorm, try to figure out what drives what we're seeing on the data, and come up with some potential strategies and solutions in the end, hopefully, to address what we're seeing. Today's the issue for today is vaccinations, COVID-19 vaccinations among DSPs. Let us see, a couple of housekeeping notes. This is going to be recorded. It is being recorded now. So if you're not comfortable with that for any reason, now's your chance to get off. The recording will be posted on our Policy Forum's website. So we'll provide a link to that afterwards. We have our colleague Nick on with us and he'll be monitoring the chat. So feel free to chime in and ask questions throughout. We'll be reading the chat, questions from the chat. Today we have Jack Reagan, who is going to co-facilitate the discussion with me. He's my colleague at ICI, and John Raffaele from NADSP, who will be our discussant, the star of the show. And I'm going to ask them to introduce themselves, and we'll get started. Jack?
Super. So my name is Jack Reagan. I also go by John. I am a 6'3". I'm wearing a green sheep sweater, and I am one of Julie's colleagues. As she said, I do workforce development and support, and I'm really excited for this forum today.
Thanks, Jack or John. I'm going to call you Jack because if I call you John, it's just going to get confusing for everybody. So Jack, nice to be with you. Julie, nice to be with you. Nice to be with everybody. My name is John Raffaele. I'm the Director of Educational Services at the National Alliance for Direct Support Professionals. Really great to be here. I'm looking forward to this conversation. I am I'm middle-aged, yes, middle-aged, white male with silver hair. I like saying silver as opposed to gray. So I have silver hair. I'm sitting in my office, I'm wearing a black shirt, and I have glasses that are clear framed. I'm sitting in my office, which is pretty cool, knotty pine wood. And I've got a really cool Japanese screen behind me. And also there's a smokestack behind me for my chimney that goes through my office. So good to be here.
Wonderful. Thank you. Okay, let's jump in. So the research issue today, the forum and the brief that we wrote is on COVID-19 vaccination rates and the DSP community. So a big part of what we were trying to focus on here is racial disparity. Was there one? And what are we really looking at for our overall vaccination rates? This includes kind of the culture surrounding our vaccination rates, which really is focused on the desire or lack of desire to get a vaccine, why people make those choices, as well as really the timing and location of vaccinations among different groups. And throughout this study, we had a lot of great support to be able to put all this together. But we're trying to really suss out some of the details as to why people are getting vaccinated or not getting vaccinated, and then really focusing on some of those racial disparities that may or may not exist. The broader focus here is really going to be on the dynamic between white versus Black, and we're talking about really kind of where those populations got vaccinated and when they got vaccinated. So that's kind of our base research issue and what we're looking into today. We do have, Julie, did we already mention that Nick is monitoring the chat for questions as we go through?
Yes.
Super. Okay. So I'll talk a little bit about the study background here, and then I'll have Julie jump in to talk about the specifics of kind of how this was all built. But ICI put this all together with NADSP to really try to create some good outreach towards our DSP population to really figure out what's been going on with them since the beginning of the pandemic, both pre and post. We're trying to continue this. And the intent is really to inform public policy and our practices and decision-making process of how we're targeting populations, how we are providing educational resources, and really how we're practically functioning within the DSP workforce. Julie, do you want to talk a little bit about kind of where we got the numbers and how the study is built?
Sure. So this is an online, was an online survey. So first thing to keep in mind, this was a third wave of the data collection. The first round took place in the early months of the pandemic when there were many unknowns about how to support people with IDD and DSPs. The first round had about almost 9,000 DSPs who completed the survey. And that was between April and May 2020. The second round was 6 months later. It incorporated some of the data elements that were not included in the first round. Also received about 9,000 responses, close to 9,000 responses. And then the data for this brief, for this study, is from the third round of data collection. That was the 12-month follow-up. And that was completed, the important thing to know here is that was completed between June and July of this year. So June, July, early this summer is when this round of data collection took place. There were about 5,400 people, both DSPs and frontline supervisors, who completed the survey. So in addition to what was collected in the previous two rounds, what was collected in this round, in this last round, and what gave us the ability to look at these data is additional questions about vaccination status, vaccination hesitancy, incentives, etc. So that's what the 12-month survey focused on, was specifically vaccinations. In terms of the demographics, since we'll be talking about sort of racial differences, in terms of the demographics, 72% of respondents in this third wave were white, 19% were Black or African American, and 9% were, as we classified for analysis, as other. That includes 2 American Indian Native American, 2% American Indian Native American, 1% Asian, 4% 2 or more races, and 2% other. We had to combine it into another category because of the small numbers, which of course is a common technique that does not allow you to look at small groups. Unfortunately, I think it's something actually methodologically in the future that we all need to start paying more attention to in terms of how we describe smaller groups, smaller diverse groups in our research. But for the purposes of what will be shown here, that's how the groups were classified. There is a link where you can find a full description, full results. That's publicly available on our website. I think that gives enough information.
Awesome. Thank you, Julie. So now we're going to jump into what our key findings were. So the key findings are focused on kind of different focal areas. race, ethnicity, timing, location, and then really that perception of what the vaccine is. One of the things that we'll be talking about later in this is how that dynamic of where people are getting information and how that fills into the broader kind of culture, the vaccine culture that's been created as a result of COVID. So our first key finding is that we're looking at 72% were either fully or partially vaccinated between June and July. And we do know that this number has increased during the last 6 months or so. But Julie, do you want to talk a little bit about why this 72% is significant?
Sure. So this, as Jack said, it is important to keep in mind that these data were June, July, before the mandates went into effect or even really were being talked about in any significant way. So keep in mind, these data, this percentage has very much likely increased since then. So with this number particularly, with 72%, that there are no differences between Black and white and other DSPs in terms of by June, July, the proportion in each group who said that they were in fact fully and partially vaccinated. So there were no significant differences by June, July of the proportions of white, Black, other DSPs who were vaccinated. They were all around 72%. That's the key takeaway from this finding.
Awesome. Thank you, Julie. So then we're going to talk a little bit about vaccination timing. So this was fairly significant when we were looking at the broad spectrum of when people were getting vaccinated, obviously between the early parts of 2020 all the way through 2021, there were some disparities between these things. So timing was pretty important. Julie, do you want to talk a little bit about the graphic here?
Sure. Thanks, Jack. Yeah, so what was interesting is that even though by June, July, the proportions, the percentages, Black, white, other DSPs were about the same, there were no significant differences. If you start looking when, like within that time period between, when did vaccination start? December 2020? Seems like so long ago, but really less than a year. But so when you start looking within that time period between December and June, July, when people got vaccinated within that time period, what you see is that white DSPs were more likely to get at least their first shot in the earlier period. So between December and March, 83% of them got their first shot of those who were vaccinated. 83% of white DSPs had their first shot in those early months. That's compared to 73% of Black DSPs who were vaccinated. 73% of them got vaccinated in that first month. So a larger proportion of Black DSPs got vaccinated later, relatively later, even though by June, July, the proportions were similar.
Awesome.
I think I'm done with that one.
Awesome. Thank you. Well, so John, can you give us a little bit of commentary on what your experience has been with vaccination timing and anything that you've seen within the workforce?
Seeing this in painted with the race and the race piece, we didn't see as much of that, and seeing this is interesting. It makes sense actually. To me, because you figure like the perfect storm of the pandemic, the racial unrest, the fact that we do know that Black and people of color do have a tendency to be a little hesitant when something like a vaccine is developed, and because we know some of the history of what has been done, with people of color and certainly Black people in and around medical experimentation and so forth, without getting into that. But I think our primary view in terms of the direct support professionals in the United States is, believe it or not, a large part of it comes from our experiences watching our Facebook page, which has about 25,000, just under 25,000 people that are very active and very engaged, very opinionated. And when it comes to timing, I believe there was indeed a hesitancy because of, these are the reasons, right? This vaccine came out too quick. The myths and misinformation around the disease itself, right? That this isn't a disease. There's other therapeutics. You can take ivermectin, and that's going to save you if you get COVID. All of this stuff and many other, much of it misinformation we saw in our Facebook community, and also anecdotally just in the trainings that we were doing throughout the beginning of the pandemic. This timing, I think it does make sense. And I think when one of the things, we'll talk about this later, one of the things that we did at the National Alliance for Direct Support Professionals was very much a validated information campaign. We did webinars and fact sheets about not only COVID, but when the vaccines were created and developed and then distributed. We did a tremendous amount of awareness campaigns about the truth behind vaccines. And I think that perhaps helped tick up the vaccination rate later on. So that's kind of our take at this point.
Awesome. Thank you, John. I appreciate it. Okay, so hopefully this wants to work. Here we go. So the next key finding that we're going to look at is the location of vaccination. So this was also fairly significant, and the numbers do kind of speak for themselves when we're talking about really access to a vaccine. And I think that's really what we're trying to target here with the location. Realistically, when you're looking at the broad spectrum of people who participated in this, we do see, some relatively similar numbers, but there were some significant disparities between these. Julie, do you want to talk a little bit about the graphic here?
Sure. So I think this graphic's fairly self-explanatory, but I mean, the big takeaway is that there are differences in where it was that people said they got vaccinated. Black DSPs were more likely to have been vaccinated at their work site or their employer office. I mean, the percentages are pretty high for everyone, 30% and above, but for Black DSPs, it's 38%. And then white DSPs were more likely to get vaccinated at a mass vaccination site or at a pop-up community or vaccination clinic. So it's an interesting and meaningful finding. For explanations, though, I think we'll turn to John.
Yeah, this is interesting. I think this is also connected not only to the things we know about the issues in and around I think Black people having some mistrust in our system and in the larger systems and so forth. But I think there's also, we're going to talk about this later, I hope, I know we will. It's how direct support professionals get their information, where they get their information. And ultimately, the third thing is the trust that direct support professionals have in their employers. I think when you look at who direct support professionals are, they're emotional people for the most part. I can say that. I can kind of make a blanket statement and say, I think direct support professionals are more likely to act on an emotional level and with an emotional appeal versus perhaps, other ways that they might be motivated to get something like a vaccine. But I think when you look at, and it's straight out there. It's showing you that employer has a major role in the life of a direct support professional. And I think we see that in other aspects of direct support professionals' lives and their careers. They rely on employers for not only their wages and the bread, but on things like information, things like healthcare access, things like, I remember I worked at a provider And one of the most popular things we did every year was a health fair, and we would have all kinds of different health related vendors come, chiropractors and massage therapists, and we would do blood drive that day. And that was an important time for direct support professionals to learn, but to also receive healthcare. So I don't think it's a mystery why so many direct support professionals were vaccinated at a provider or an employer's site. I that makes sense to me. And I think also, given the demographics of direct support professionals, when you look at their ability to go to the pharmacy, which might be 20 miles away if it's a rural situation, right? That's not as easy when you're working 2 jobs, when you have 3 kids, to just hop into your car, which you may or may not have enough money for gas to get you to the pharmacy or the pop-up clinic or a mass vaccination site. So that's kind of my take on these numbers.
Awesome. Thank you, John. And, I think it speaks volume when we're talking, as we kind of delineate down into some of these other key findings. I think you're going to find they blend into each other really well, because the data is really indicative of this kind of culture of mistrust as well as trust. It's a combination of both of them. So thank you for your input, John. I appreciate it. So I think this translates really well to what John was mentioning here in the beginning, where we're talking about the common reasons for not wanting to be vaccinated. So this is really that culture of trust and mistrust. Where are we finding some of those gaps, and why are people reporting this way, I think is really that broader question. Again, the graphic is relatively self-explanatory, but Julie, do you want to talk a little bit about the numbers and why those are significant?
Yeah, thanks, Jack. So we asked for people who indicated that they were not vaccinated. We asked the reasons for why they were not vaccinated. These are basically the top 3. These are not exclusive of what we asked. So the other choices that people could mark is not eligible, cost, or difficulty accessing a place and time offered. Somewhat surprisingly, I guess, but then again, this is June, July. So again, timing is important. Somewhat surprisingly, eligibility, cost, difficulty accessing was not a common factor, really. None of them, I think, rose above like 5% for anybody. And there were no differences between Black, white, and other DSPs in those areas either. But just in general, cost, eligibility, difficulty with access were not really factors at this point. Not by June, July, at least, and not according to this study. The major factors were not feeling that the vaccine is safe, not believing in the worth of the vaccine, and just this general feeling of I don't need it. And there were some differences here in terms of Black and white DSPs and how often they gave these reasons. White DSPs were actually more likely to say that they did not feel it safe, and more likely to say that they did not believe in the worth of it, and somewhat more likely to say that they did not feel the need for it. So pretty much all of these reasons, it was actually white DSPs that were more likely to give these reasons.
Yeah, and I think that kind of tails back into our conversation of how do people get their information? So, John, I'd love to hear a little bit about what your experience has been with that, especially with the Facebook page.
Well, do we have 4 or 5 hours to talk this up? Because I think this is probably what I would say. This is the one thing that we saw that alarmed us more than anything, right? So it was about, I think, how people get their information, which is largely, we know our society gets a large portion of their information from mass media, from social media. So, and I think number 2, it's we have to bring in some politics here. This whole vaccination COVID-19 dilemma that this planet is still undergoing, it became obviously very politicized. And I think that went right into the avenues and the channels and the ways in which information was promulgated. And what we saw on the Facebook page, there was no gray. There was really no gray area. The opinions were strong. The opinions were passionate. Some of the opinions were informed with validated, what we would consider accurate and non-adulterated information. But I think there was a large proportion of direct support professionals that would write whatever transactions they would have on the Facebook page, and they would be firmly in belief about what we know that wasn't science-based, right? Up to and including all the stuff around, if you get this vaccine, you're not only a sheep, and you're going to get a chip in you that's going to follow you, and the government's going to follow. We saw all that. I mean, what we consider the very dangerous misinformation that we have all probably have seen in the larger society and our larger media, but on our Facebook page, it was really a microcosm of what was going on out in the rest of the world. And that was alarming to us, because here's where our mission at the National Alliance for Direct Support Professionals is to elevate the profession, right? To elevate direct support into where it should be as a bona fide, respected profession with a code of ethics, with competencies. And what we saw deteriorate in these conversations was that professional obligation that one has being a direct support professional. I'm not saying all of the commentary was that, but a lot of it was, and it was very disturbing to us. And it was based on information. It was based on how direct support professionals get their information. And that's, I think, what prompted us as an organization to really spend a tremendous amount of time making sure what we put out there, we made it accessible and free, and we put it on as many social media outlets and channels as possible. We shared everything, but we also made sure it was valid, it was research-based, it was rooted in science. And hopefully that helped with some of the conversation on Facebook. But even to this day, I didn't check it this morning because I didn't want to get all upset before this policy forum. Even to this day, there are issues in the conversations that happen between the professionals on that Facebook page. And it frankly, we have lots of work to do to help direct support professionals understand their obligation to, if they're going to be supporting people with disabilities, they need to understand that they have an obligation to understand science a little bit more, perhaps, than they do, and not, and take some of the politics out of it, take some of maybe your opinions out of it, and go to the code of ethics, go to the competencies. And that's where I think some employers are very good, and they push that and they promote that, and they want their direct support professionals to understand what they do. They have a professional obligation to promote the physical and emotional health of people. And that's in our code of ethics. That's in our competencies. And I don't think we saw a lot of that being necessarily reinforced. It was very much opinion rooted. And where those opinions came from was, I think, an abundance of misinformation and conspiracy theories and all that other stuff. So it was alarming to us.
Yeah, awesome. Thank you, John. It really seems like there's a strong relationship between that passion in politics versus the evidence-based practice that you're really trying to push out there into the community to help that conversation. So thank you for that. Thank you for the commentary and for the work that you do.
Sure.
Okay, so another piece of this that's really important is the employer support. So how are people able to or not able to get the vaccine. We all know that DSPs are incredibly essential. And oftentimes, especially with a workforce shortage, we're looking at really challenging circumstances when you're going to get a shot. And if it's going to make you sick for 2 or 3 days, it's going to be hard to go and pursue your profession. So realistically, we wanted to take a look at what types of incentives and what types of support are employers providing so that they can really make sure that they have a safe provider network between the DSPs and the people that they support. Julie, do you want to talk a little bit about our data here?
Yeah, so we also, actually, this is not shown here, and there's a reason for that, but we also did ask about employer mandates and whether your employer mandates you to get a vaccine. We're not even showing that data because this was back in June, July. It's really no longer relevant. Much has changed since then, but at the time it was pretty low. I think it was lower than 20%. However, this is still going to be relevant. We asked whether people's employers, DSP's employer, offered paid time off to get vaccinated. And as you will see, 3/4 basically overall said no, that there was no paid time off for them available to go and get vaccinated or afterwards if they needed it. There were no significant differences between Black, white, other DSPs. So we're showing it by different groups, but really there are these differences are not significant. Similarly, there are no significant differences when DSPs were asked whether there was a financial incentive, and the financial incentive meant that it could either be provided by their employer or the state. So basically, if your state, was like Minnesota was giving away, like I think $100 or $200 to everybody who got vaccinated for a while. So again, about 3/4 said that neither their employer nor the state was offering any financial incentive to get vaccinated. And again, there are no differences between groups. The one thing I will add about this is that whether it's actually not entirely known to me whether these numbers are accurate, because this is whether people know whether there are financial incentives. So there could be financial incentives, but people do not know about them. And if they do not know about them, they might as well not exist. So just a sort of a caveat here too, that these numbers, this is about knowing whether there is a financial incentive.
And if I can just jump in, Jack and Julie,
Go for it.
this is a double-edged sword here, This, and I remember seeing and hearing direct support professionals, whether they were in trainings or on this Facebook page, anecdotally, hey, if this vaccine is so safe, why are you kind of bribing me to paying me to take it? I think there was that piece that I think kind of contributed to a little mistrust, right? Okay, in the very early stages, especially, right? I remember there were articles where it was healthcare facilities and nursing homes and assisted living facilities. They were featured, I think, in all different major publications, Wall Street Journal, New York Times, about these financial incentives early on in the vaccination campaign. So I think it led to once again another layer of this confusion around vaccines. Are they safe? Why are you paying me to get a vaccine? And if you think about that, I think that's compelling. The other side of this, direct support professionals don't make a heck of a lot of money, and there is, $200, $300, some kind of bonus to get the jab. That is also appealing. So when you look at this from that view of how a direct support professional thinks, I think it's very interesting. These numbers about financial incentives, whether it's paid time off or some kind of bonus to get the jab, how that may or may not be relevant to a direct support professional's ultimate decision to get a vaccination.
Mm-hmm. Yeah, yeah. One of the other things that we had looked at was the percentage of migrant workers who were holding more than one job and sending money back to family members. And I think that kind of hits the nail on the head, John, with that comment of a $200 financial incentive can be very significant depending on what your situation is. So thank you.
And think about that, that's okay. I'll take that sacrifice for my family, whatever, vaccine side effects be damned, or, what's going to happen to me getting the vaccine long term be damned. I'm going to do this for my family. So, yeah, it makes sense.
Mm-hmm. Awesome. Thank you. Here we go. So the next piece of this is talking about what the policy recommendations would be for supporting these types of findings. Realistically, what we're looking at is broad spectrum engagement. How do we create a more positive vaccine culture? And creating that model requires quite a bit of commentary on what our kind of cultural biases might be, as well as what is the reality of the life of a DSP. So how do we really make this truly an accessible thing to create a positive culture? So one of these big pieces is that equitable access. So when we're looking at that timing and location, we want to make sure that we're providing recommendations to our systems to be able to support people in a way that's going to allow them access to the vaccine without fear of maybe losing some of those hours. Because again, like we talked about, those hours are significant. People in DSPs are not really willing to give up shifts when, again, you're not paid very much. So you're trying to work as much as you possibly can. So equitable access is really important. And part of that is the provider world, and part of that is also what can we do to support the DSP in that conversation. The next piece of this is that we want to create policies that are really focused on that evidence-based practice so we can address some of that fear and mistrust that we know exists out there. And again, this is going to fall back onto that conversation of where do people get their information? How do we provide a stronger culture on what types of information is out there? So John, like you said, you were very focused on making sure that this was all evidence-based, everything that went out. So that way people did have a solid source to be able to go to. But at the same time, we also need to be doing this in a way that we're respecting the mass diversity that exists within our DSP workforce. We want it to be evidence-based practice, but we also don't want it to come off as potentially targeted or offensive. And that can be a very challenging line to tiptoe, realistically. So we don't want to compromise anything at the same time of providing as much information as we possibly can in a very fair and culturally appropriate way. Oops, sorry, this keeps clicking on me. Here we go. Then we also want to address the overall vaccination rates. I mean, that's a national incentive that we're all trying to support, but realistically, we do need to create some levels of targeted marketing to make sure we can hit some of these disparities that we know exist. One of the big points that struck with me was when we were talking about the timing of the vaccine. So it's also timing of information received. I think that has a huge impact on when and why people are getting vaccinations. So we want to reduce that disparity that we know exists between that timing and realistically the location. But I think the timing is one of those pieces that we really want to address from a policy perspective. And then we want to offer as much support as we possibly can to employers to make sure that there are options for DSPs to be able to go and get vaccinations without having the fear of maybe losing hours or potentially something like reduced pay. We want to make sure that there's options for people to be able to go and get vaccines at the same time of supporting their personal health, personal well-being. And realistically, I think this comes into the conversation of what we're talking about for overtime and burnout. When if you have a smaller percentage in let's say it's a small agency, you have a small percentage of people who might have gotten the vaccine right away, but some of those people might be working really intense levels of overtime, which is going to create some intense burnout, which is going to have backlash on the DSPs as well as the people who we support. So we want to make sure that some of those policies are also going to be reflective of how can we provide support to the employers, to the providers, to be able to support the workforce, to maintain a really healthy and stable longevity. Okay, so now, let's see, it keeps doing this. Here we go. So now we're going to hop into the Q&A section. So if anybody has had questions that you've been typing in the chat, Nick has been monitoring that. And we'll kind of go through some of these, and we have some specific questions that we'd like to ask everybody. So I'd like to address those first before we come into some of the chat questions. But again, we want this to try to be a little bit free flowing and offer people an opportunity to provide some commentary on the research that we've done.
So Jack, sorry, just before we actually jump into the discussion questions, let's pause and ask folks who are attending whether there are any questions for us before we hopefully start talking together. So if there are any questions for John especially, or for myself or for Jack, now is a good time to ask. If not, we'll move on to the discussion. And I don't think there were any questions in the chat other than whether the slides will be available, and they certainly will be.
No, just a couple comments. Yeah. But Joe Macbeth, hi Joe, indicated when I was talking about access. Hi, there's Joe. Access to being able to even go to get a vaccine. You know, if it's not at the employer, it's very difficult because you're working double shifts, you're working overnight shifts, you're tired. You know, you're worried of those side effects, right? That you might get getting the vaccine. And that's going to prevent you from going to work. And if you don't get PTO for side effects for the vaccine, all tied into, right, Jackie, you just talked about how do we create policies and organizations to really honor the kind of the pickle direct support professionals are in. So thanks for putting that, and getting time away from work is often difficult, Joe indicates, and it's so true for direct support professionals.
All right, doesn't sound like we have questions. So let's look. Oh, John Nadorf just put a question in chat. Did people report that employers made space to address questions, concerns on the vax? I'll answer that. This was not an explicit question on the surveys on a part of the study. So we can't answer that from this data, but this is probably something that John can chime in on. Sure.
I think, John, thanks for the question. I think it really depended on, I think the provider, that employer, where they saw the value of offering that type of information. And I think many did. But I think providers are also confused, as we all were confused. We're still a little confused about what do we tell people about the Johnson & Johnson vaccine versus the mRNA vaccine. Do we get into the weeds with that? How much do we get into the weeds with that? When we provided our informational webinars, we had an expert on mRNA vaccines and a medical doctor talk very simply about what these were about, how they were made, how their history, the fact that they weren't developed in warp speed necessarily. And I think sometimes the provider, the employer, got a little nervous about giving information that was, even to this day, it's changing all the time. So I think what providers wound up doing or employers wound up doing is they did their best. And again, anecdotally from our observation on our Facebook community and what we heard through our connections throughout North America, I think most providers did what they could do, but I think there was hesitancy because the information was changing so rapidly. I hope
Awesome.
that answers your question, John.
Okay, does anybody else have a question that they'd like to ask before we jump into some of the questions we prepped for you? No? Okay. Okay, let's do it. So, we've talked a lot about this today of where do DSPs get their information? And realistically, we know that there's a massive spectrum of where people get information. I mean, these days you have people who are consistently using YouTube as a method of getting news or basic info. And then some of these organizations took some hard stances. YouTube did make a mandate where they took out everything that was misinformation on vaccine culture. And that's a huge step to be taken with an organization that large. But on the average, we want to talk a little bit more about where we think DSPs are getting their information and how can we create a stronger culture for evidence-based practice information. So what else can we keep proliferating out into the community?
And this is just open for everyone. The idea is to just try to get, try to generate a discussion, but also new information, potential strategies, solutions, food for thought, further research, etc. Or if you want to just unload and talk about what you know, or what you have seen, or the stories that you want to share, this is the place to do that as well.
Joe Macbeth says, are we going to open this up to voice or just, okay, wait, Joe, do you want to unmute? Because I think that's important, what you just said.
I love these policy forums, Julie and Jack and everybody at the University of Minnesota. Yeah, what I wrote in the chat was I don't think DSPs typically are engaged with their professional cohort as well as they should be. I don't think direct support professionals are engaged with their colleagues from around the country. Like other professions are part of a professional membership organization. Certainly administrators or executives in our field belong to ANCOR or their statewide professional membership organization. They get good, solid information from those organizations about their work. John, you're a social worker. You probably belong to the National Association for Social Workers. You get good, solid information about social work from that organization.
Yep.
Direct support professionals are relying on coworkers, and as Jack said, YouTube and other unreliable sources. The reality is our two organizations, ICI and NADSP, puts out this great literature in the Frontline Initiative, this newsletter, a great source for direct support material. It's not being used. So how can we get DSPs to be more engaged with the importance of their work? I know that's answering a question with a question, but there you go. That's what I think, John. And you and I have talked about this for years.
And if I can piggyback on that, I think, and it's we got to be careful. We got to be careful with the providers, right? They have all these requirements, especially now in a time of a pandemic, and everything is health related and safety related and exposure control. And before the pandemic, most training directors in organizations, you know what they're pushing? They're pushing the regulatory training. They're pushing the stuff that has to be done. It's important stuff, the HIPAA, abuse prevention, abuse reporting, CPR, first aid, good stuff. That's all good stuff. But the real good stuff, how to, when it comes to, how to be person-centered when you're wearing a mask, working with people that ultimately might communicate through facial expression. Where's the training on that? You're not going to see it. And you're going to see the poor provider agencies wind up inundated with what they're required to give their direct support professionals based on whatever news coming down from the state. And so even before the pandemic, information was generally limited. It wasn't what we, probably everybody on this call, would consider the real soul of direct support, which is how do you communicate with somebody that communicates in a non-traditional way? How do you intervene or prevent a crisis in a way that doesn't require restraining somebody? All that nuanced stuff, that's very rare that you find that in the regular educational development for direct support professionals. So I'll shut up, because I can go on all day. I'll shut up, I'm sorry.
So John, I'm going to jump in here. This is Julie. I actually found it really interesting when you said that, providers themselves also did not and continue to not have the right information. So it's like a perfect storm. There's the DSPs who rely on their employers, right, to one, as we have seen, even provide access to vaccinations, but then also for information. And then the employers themselves don't have that information. So where do they get it as well? I mean, they have to figure out this regulatory environment, and then this CDC, FDA, who says what, which day, and then they somehow have to summarize all this information and transform it into something that will be actionable, understandable, accessible, and appropriate for DSPs. And it seems like such a complex, perfect storm problem. But it's not just on DSPs, obviously.
Yep.
It's not even mostly on DSPs, right? It's what the providers are able and can do, and where they get that information, and then how they use that information it seems to me also a huge key part. And I think Jessica had a raised hand here. You don't have to, by the way, if you want to talk, please do not. You don't have to raise your hand. Just unmute yourself and say.
Okay, sure. Yeah, I was just going to point out what I've been seeing lately, especially with, I was a little surprised at the number of, I think it was something around 75% of employers that aren't giving people time off. What I've seen is that pharmacies are stretched very thin, so they can only do so many clinics for these places, and they have very short windows of time that they can do it in. And then these group homes are stretched so thin with their employees that they don't have anybody who can cover the employees that are working, or they don't have enough, managerial staff that can step in during that time. Plus these homes are spread out, some places that are 30 or 40-minute drive away from where they're going to have this clinic. So I guess that's kind of the barriers that I've been seeing a lot lately with DSPs and with group home employees, is just the lack of staffing to cover and the lack of clinics that are available at times when they can come, when they're able to make it. So
Thank you for that.
John,
I just want to read.
I'm sorry, Julie. Yeah.
I just want to read a couple of comments in chat.
Yeah.
Again, there's one from Joe, just piggybacking on what we were saying earlier, that DSPs need effective and transparent communication from their employers. And then from John Nadorf, related to his question before, I've heard anecdotally that organizations that gave skeptical people a chance to air their concerns and address them with empathy and science effectively got people on board with getting vaccinated.
Yeah.
John Nadorf, do you want to talk more about that, or you certainly don't have to, but if you wanted to give more context.
The only thing that's coming to mind about that was I think in the NBA versus the WNBA, the rates that players agreed to get vaccinated, and there were people reporting that in the WNBA, they were really intentional about creating space to have these conversations about safety and different concerns that come up around it. And they were like 99% effective, or, 99% vaccination rate versus the NBA's significantly lower rate. And I just thought that just makes sense to me with how people think and how people change like political views or views about society and science and stuff like that. So I would just be curious that employers that might have done that really intentionally, how much more successful they might have been.
Mhm. To piggyback on that, Jonathan, I would say it goes back to that trusted source, right? The trusted source. And when you, once again, you look at many direct support professionals, their lives center around their work and their employer. A lot of direct support professionals are proud, not only be direct support professionals, but they're proud to work for ABC agency, whatever, right? And it's those agencies that can be an extension of their family, can be an extension of their community, right? DSP spend a lot of time at work. And if that, you said, I love offering that space to talk about your fears, to talk about your hesitations in a non-judgmental way, in a way that gives you, here's the evidence that we have from our trusted sources, from the trusted source being that provider. It just makes sense. One quick anecdote, and Pete is on the call here. Pete Macaulay, hi Pete. We did a couple weeks ago, we did a whole week of filming public service announcements. And hey, there's Pete saying hello. And we interviewed this one direct support professional. These were public service announcements that are meant to promote vaccine, right? Getting the vaccine. So, and Jerry Smith was interviewing this one direct support professional. And she was saying that she didn't want to get the vaccine, and it was based on religion and her religious beliefs. And Jerry wonderfully, gently, empathically was probing a little bit with this interview. I don't know if you remember this, Pete. And she kind of got a little bit confused. And well, it's not really my religion; it's more my personal beliefs. And Jerry was very gentle and said, well, this is what we know about vaccines. And I can tell you from my knowledge from the CDC and from medicine and science, this is how the vaccines work. And I think she was concerned about fertility and fertility being perhaps something that was going to be affected getting a vaccine. She was probably a 21 or 22-year-old young woman. And so we took the film, we got the film in the can. And Pete, this is for you. I got a message a week later from the person that organized this, the filming from this agency. She went and got a vaccine. And that, again, I think that's, once again, you can extrapolate from that. She had the space, she was given the space to talk about her fears in a non-judgmental way with, I think, a fairly trusted figure. And she made a decision to get a vaccine. And I don't know if it was Jerry or you, Pete, or me. It doesn't really matter. What matters is, I think what Jonathan's getting at, empathy, and obviously science, but I think empathy is a big thing for direct support professionals. I really believe that. They're emotional creatures, and that's okay. That's good. Not that they're not going to buy into science, but I think we got to get their hearts. And once we get their hearts, I think we can, and we can't be diabolical about that either. We can't manipulate people, but we also know that I think direct support professionals, they work from their heart. So that's my piggyback on your comment there, Jonathan.
Anybody else wants to chime in here? And we can talk about this probably for a long time.
Yep. Okay, well, if people want to come back to this question because you think of something you'd like to talk about, absolutely. I think we'll prompt with another question and see what else we can parse out here. So we've kind of talked a little bit about this, but the strategies for increasing those vaccination rates. And John, I think that interview is a perfect example of things that we can do to create that safe space and create that positive vaccine culture. We're using that evidence, but also it does at some point, it takes a special type of character to do that. And Jerry happens to be one of those people who has has a phenomenal skill at interviewing, but also creating that environment to open up the conversation. So I guess, to everybody, what are some of these strategies that we can use? And, do we need to have more Jerrys and Johns and Pauls out there to be able to really create a more positive culture here?
Well, I personally was really kind of quite taken by John's comment about the provider role in this, and the importance of the employer having the information and being able to talk about it, translated information in the right way. I mean, we can't clone Jerry's, unfortunately. Wish we could, but what can be done sort of at the work site in terms of creating those spaces, figuring out who that trusted source can be, and then creating the right information in the right form. Trust is a huge thing. I agree.
Julie, around Minnesota, one of the things that comes to my mind is organizations people trust are rooted in what they're willing to do to support the constituency, to support the people. So I think organizations like, NAMI and ARC and Awesome, they have tremendous bandwidth to be able to access and build some of that extra trust. So maybe do providers need to lean a little bit more on some of these advocacy organizations to help proliferate that information? And not all providers are going to have the capacity to be able to really address some of the cross-cultural boundaries that might exist in some of this information, where some of these other organizations can. So I think one of those things we can do is involve some of those advocacy networks to help really bolster what the provider is able to do to support their staff.
And one other point, thought. So speaking of PSAs, public service announcements and videos, we've also at ICI we've also produced a few of those, and they're also, I think the commonality here is that they get at that emotional and responsibility aspect of why you should get vaccinated. I do wonder at this point, when we have this group of people who are kind of refusing to get vaccinated at this point for probably slightly different reasons than what was earlier. The reasons that people had for refusal earlier are probably slightly different now, and the people who are still refusing are probably more entrenched in that refusal than before. So I do wonder about sort of the marginal utility of those emotional appeals at this point, and how much they move the needle. I don't know. Just a thought for discussion.
Julie, I hear you. I hear you. Those folks that are entrenched, right? It might even be detrimental. You're not gonna get me to change my mind with your hard on your sleeve emotional appeal to me, because I believe whatever conspiracy theory, whatever non-scientific base is, right? And one thing, once again, the polarization of those that are vaccinated, those that aren't, at least in the direct support professional Facebook community, and what we know, again, anecdotally, it's really only anecdotally that we can state this, but it's, my goodness, it's extensive. That chasm seems to be widening, right, between those that are vaccinated that are now beginning, we're seeing some of the commentary being, you know what, I'm vaccinated because you know what, I care about the people that, you know, I support. And those that aren't vaccinated, right? Don't. You're just pawns in a system that's out there to exploit you, and you're going to eventually, you know, have horns and a tail because of the vaccines. Essentially, that's kind of that's the entrenchment. And I don't know. You're right. I'm concerned. You know, how do we move the needle on those entrenched folks without creating essentially a civil war inside our direct support community? And I don't know. I don't know the answer to that, but it does worry me. So that's a great point, Julie.
If anybody has solutions, please chime in here. We'll take them. Barb, that is a very long chat message. Barb, do you want to just say it instead of me reading it out loud? Are you able
Sure.
to speak?
I'll just read
Okay.
it out loud. I'm much better at writing than I am speaking today. Really what I was pointing out is it just from what I'm listening in, and this has been a really excellent, thoughtful conversation. It really seems to me that the same strategies that we draw on, and I think it might have been something that John Raffaele said, when I think about supporting a person with a disability or a family member and making informed decisions, those same strategies, employers can apply those same strategies. So some of the things that John was talking about really are some of the same strategies that we would think about or that I would look at in terms of informed decisions. Because that's really, I think, what we're talking about is how do we support direct support professionals to make a informed decision. And amidst all of the misinformation and biased information that's out there. And I agreed that there's, you know, offering that non-judgmental, unbiased, neutral space for DSPs to discuss their concerns is needed. My concern is, or my challenge has been that I've noticed an increasingly compliance-driven kind of aura, if you will, happening, which often is in tension with person-centered practices or person-centered organizational work. And it makes it difficult for providers to offer that kind of safe space or that space for employees. And they think about vaccine mandates and even those, the information is not clear. There's misinformation out there, and then there's also unclear information. Even at the university, we struggle with the changing protocols and what we need to follow. And I think particularly those smaller providers who are just trying to stay afloat, and how do they do that? But there are some good examples of employers who have figured it out. We have a couple in Minnesota, and I think John mentions a different organization as well. Anyways, my concern is just that the mandates and the discussion around COVID has the pendulum swinging back towards kind of that compliance focus and what that would ultimately mean. How do we balance that with services for people too? Mm-hmm. So, like I said, it's better to write it than to say it. And I'd invite others to comment.
I'm going to actually jump in here as well, because the mandates themselves are so sort of an interesting factor as well. Of course, we know that they're effective. However, we also are starting to see that the mandates are starting to contribute to the already untenable shortage situation, right, within this workforce. I mean, some DSPs are in fact choosing to leave their jobs. From, you know, anecdotally for now, I don't think there's been any hard data on this yet. But certainly anecdotally, we are seeing DSPs leaving their jobs rather than get vaccinated. It's a balance, I guess. I mean, as with all things, but considering that this workforce was in crisis already, you know, it's certainly not helping.
No, 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 I'm thinking back to, being in this world for, gosh, almost 35 years, actually over 35 years now, working in provider networks and individual provider organizations. The state will dictate something, right? And I'm not talking even about like a large mandate of a vaccine. I'm talking about some kind of policy comes down from the state. And bless all the state folks that are with us today. We love you. We need you. You drive us a little banana sometimes, but you're there to make sure we're keeping our part of the contract. But the reality is, providers and those individuals within the provider communities, we get cynical about a mandate. We get cynical about this. You wrote it, Barbara. Compliance culture. We got to be compliant. And this is something that goes beyond compliance, right? This is something that deals with quite literally the lives and deaths of people with disabilities. And it's getting that's maybe even getting lost in all of this mandate and this, the heavy-handed stuff that's happening around mandating and things like this. Yeah, I think we come from a system that we get the dictums, the dictates, whatever you call it, and we do them, and then we report back what we did, and either we've done them well and we get accolades and we get funded, or we get, we've got to do a plan of corrective action, to fix what we've messed up, as opposed to doing things that are morally, ethically, and ultimately, you want to get to it, something person-centered if we're going to be in this business. So I that's my take on this thread of the conversation.
Yeah, I think within the idea of person-centered planning, it actually, this really comes into play, I think, to say good to versus good for. And I think we need to use that mentality with DSPs to really try to help what's going on here.
John, Raphael, did you just put a heart on your?
I did, because I just like Jack, what he said, because this is important for territory. It really is when it boils down to it. It's important for, my goodness, it's both ends, in my opinion.
Well, and this is Barb, and I think the balance of that, and I agree with you, Jack, the challenge is always what's that balance? And the 2 and 4 for an individual, as John Raphael talked about, who's getting services and supports, and the balance of 2 and 4 and the people that are providing them. And I think what John, the story you shared, John Raphael, the story you shared about what you experienced with Jerry and Pete and being out with that person. What I saw is you created space to have a discussion around the importance of the 4, what's important for her, the individual, and also what's important to her. And by creating that space, you give people the opportunity to think through and maybe get some more information or look at a different source or think about it a different way, so that they make an informed decision. Some people will make an informed decision. They're that strong in their convictions about all vaccinations for some people, that they will make the decision to, something is important for them. They will make having income or a job. The job might be important to them, working with this specific field, but they may make that decision to leave. And I think that's the challenge, is how do we minimize vacancies or, that turnover, because we're in a time when our field we can't afford that. Any to lose for those particular reasons. And so, that's, I think the opportunity is to how to work with organizations, and those organizations that are already embracing person-centered practices and that kind of 2-4 dichotomy, keeping it from a dichotomy of an either or, but kind of how do you have a both and.
Mm-hmm. Awesome. Thank you, Barb. Out of respect for everyone's time, unless anyone has a final comment, I think we'd like to wrap up here so we can get moving. Does anybody else have a final comment they'd like to toss out? Okay. So just to wrap up, the policy forums happen every single month. We'll keep sending this out to everybody. If you have any questions, comments, or ideas, please send that to Julie or myself. It was lovely to have everybody on here. I think that was a fantastic conversation. And John, again, thank you for being on. Your input is just invaluable. Thank you.
Great, thanks. It was great to hang out with you, talk about these important things, and solve the world's problems in an hour and a half.
Thank you, everyone.
Bye, everybody.
Bye, everyone.